करा था आपने?
Ajay, are we live?
Hello.
No, ma'am. Just a second.
Okay.
Now we are live, ma'am. You can start.
Yes.
A very good evening to one and all. On behalf of Human Biological Institute, a division of Indian Immunologicals Limited, I welcome each one of you in today's enlightening session of recurrent pregnancy loss in association with the Obstetrical and Gynecological Society, Meerut. I'm extremely honored to welcome our esteemed chief guest, speaker, and panelist for today's session. Can't wait to hear out the eminent experts of our country speaking on the such an important topic, recurrent pregnancy loss. But before we begin the session, I would like to take this opportunity to present a short brief about Human Biological Institute. Human Biological Institute, a division of Indian Immunologicals Limited, IIL, was established by National Dairy Development Board, NDDB, in the year 1982. HBA was established in the year 1998 when Government of India requested IIL to produce a modern tissue culture anti-rabies vaccine to phase out the old unsafe nerve tissue vaccine. The first manufacturing facility of HPI was established at Ooty. The facility is one of its kind in India to have rolled out first Vero cell culture rabies vaccine in 2000. Subsequently, HPI launched other vaccines, and currently we are the major player in human vaccines. We are the leader in ARV and present in more than 50 countries with 3 state-of-the-art manufacturing facilities in Ooty, Gachibowli, and Karkapatla, also known as Genome Valley. Indian Immunological Limited, we share our vision by shaping global healthcare by spearheading the One Health initiative with a mission to innovate, produce, and market quality healthcare products and services to improve and extend life. And we truly believe in providing affordable products with high quality through continuous technical innovations and improvements to meet our customers' demand. It's a privilege to also mention that we have a dedicated scientist working with the Research and Development Department of us. And the current pipeline includes us working on COVID-19 vaccine, which hopefully soon will be rolled out next year. Moving forward, the other vaccines seems hepatitis A, measles rubella vaccine, chikungunya vaccine, rabies therapeutic monoclonal antibodies, typhoid conjugate, dengue vaccine, Zika vaccine, varicella, and pneumococcal conjugate vaccine. Human Biological Institute, in IAL, with the flagship brand Abherab and Abherab PF, the ARV, saves millions of lives every year with over 20 years of trust. And yes, we save 40, through Abherab, every minute 40 vaccinations happen across the globe. Apart from this, Human Biological Institute has also ventured into other areas of disease prevention through its range of wellness products such as probiotics, nutritional supplements, and hormones for infertility, and specifically for the segment of puberty to menopause. Also would like to mention that Human Biological Institute has introduced its specific domain, pubertytomenopause.com, for women of all age group for the healthcare needs. Human Biological Institute, a division of Indian Immunologicals Limited, truly believes in its corporate social responsibilities. Either it is our contribution to PM Care Fund for Corona, for fight against Corona, or adopting government schools where the strength of the children in the adopted schools have been doubled within a few years. And also we are proudly associated with NDTB for a gift milk program where over 1,600 kids of Telangana and Andhra Pradesh are benefited. I'm very much thankful to all of you for your patience listening about Human Biological Institute. So without a further ado, it's a privilege to welcome Dr. Priyanka Garg, the prime convener of today's program. She currently Secretary of Obstetric Gynecology Society, Meerut, 2020-2021. With over more than 15 years of surgical and academic experience, she has also been an associate professor in LLRM Medical College, where she has completed her postgraduate. She is one of the first in Meerut to pioneer stitchless hysterectomy, advanced gynec endoscopy, and many other practices in Meerut. She has pioneered active colposcopy and lip biopsy in cervical lesions and first time in mirror to perform independent artery ligations and embolization of AV malformations. With this, I request Dr. Priyanka Garg to kindly guide us for the program ahead.
Thank you, Payal.
Dr. Priyanka ma'am, over to you.
Thank you, Payal. It's a proud privilege for Meritopsin and Gynae Society to have Dr. Rishikesh Pai sir with us. I, as Secretary and Treasurer to the Merit Society, welcome you all to this web meeting, which is jointly organized by Meritopsin and Gynae Society with Human Biological Institute. In these tasking times, when this COVID-19 virus has hit us hard in super pandemic proportions, I would say, we assure our support to all those members who have lost their near and dear ones in this pandemic, and at the same time offer our prayers for those still struggling with the disease. At the same time, we express our sincere gratitude towards all our members who are working tirelessly day and night to serve mankind in these times. We just pray for each and everybody's health. So now I would like, कुछ भी शुरू करना होता है तो उसके लिए बड़ों की blessings की आवश्यकता होती है. So I would request our patron madam, Dr. Usha Sharma ma'am, to say a few words for blessing for all of us.
Thank you very much, Priyanka. You very rightly said कि ये ऐसा समय है जब हमारे लिए बहुत जरूरी है कि हम सब उन लोगों के लिए प्रार्थना करें जिनके रिश्तेदार या खुद वो इस समस्या से फंसे हुए हैं, और मुझे पूरी आशा है कि ईश्वर हम सबकी प्रार्थना जरूर सुनेगा. We have with us today Dr. Rishikesh Pai. मैं ऋषिकेश के लिए क्या कहूँ? He is such a wonderful person, a dynamic personality, a dedicated personality, a very loving and affectionate person. And the biggest thing is that he is very, very approachable person. And I tell you, Rishikesh, we all are great fan of yours. Even I told Priyanka that Reshma yesterday when we were together that I am not only your admirer, but I am a great admirer of Rishikesh also. And our president, Dr. Kirti Dubey, we can also see that though she is in America, but she is so much interested in the activities of our society that she is there early in the morning, because as her time it is around about 8 o'clock in the morning. Our vice president, a very dedicated, hardworking, who is holding post in Foxy also as chairperson, MTP committee, and a very active member, and then dynamic secretary, whom I always appreciate, that you can always see her smiling, whatever may be her problem, but you cannot find anything from her face. And we are going to have a very interesting discussion today on recurrent pregnancy loss. All of us know that it is physically, emotionally a very challenging topic, not only for the couple, but for the clinician also. And it is though very frustrating, but is amenable to treatment. And today, we know just now as we were discussing that there are so many recent advancements every day regarding recurrent pregnancy loss as regards diagnosis and the treatment, that it's really very, very important to update your knowledge. Otherwise, it will not be possible to provide any services to such persons who are really frustrated and very much disappointed. So, updated knowledge along with the loving, tender care for these patients is the key to success. And we have got with us as chairpersons none other than Dr. Rukma Idnani, a very senior person and past vice president, president of our society, and then Dr. Manjula Lakhanpar. Both are very active, and we have got really a cream of persons as panelists today. Kirti Dubey, Bharti Maheshwari, Priyanka, Anju Rastogi, and Nisha Jain. I am sure that the deliberations will be very, very fruitful and will go a long way in updating the knowledge of every person who is attending this webinar. Once again, Priyanka, I really congratulate you for organizing this webinar on such an important topic. Though we have listened it so many times, but daily there is something new to listen and to just know about it. Thank you very much once again. With these words, I welcome you all on the occasion of this webinar on recurrent pregnancy loss. Thank you.
ma'am. Ma'am, we all know that Dr. Rishikesh Pai sir is an encyclopedia on knowledge. And earlier treatment of RPL was just tender loving care. But now with the use of latest technologies, things have changed markedly. And all of the advancements have been pioneered in India under the guidance of Dr. Rishikesh Pai sir and Dr. Rishma Pai madam. I would request our president, Dr. Kirti Dubey ma'am, to please bless us with a few words.
Good evening, everybody. I am really fortunate to be with you all and to be informed by my secretary about this webinar. Otherwise, if not informed, I would have really missed this webinar, which is going to be so interesting and so, I would say, rejuvenating. Things which we already know, but still we have to know many more things in the upcoming ones. Thank you, Priyanka. Thank you, Dr. Sharma, for making me join this webinar. And I'm privileged to, and of course, I have this opportunity of welcoming Dr. Pai, who is, as Dr. Sharma has already said, that he's a dynamic personality, an eminent gynecologist of India who is with us and who would add to what already we have a little knowledge of recurrent pregnancy loss. Thank you.
Madam has been one of the most experienced professors and clinicians of Meerut with a large variety of interest. So many cases of RPL being treated by her, and till date, we learn from her. I always have a nick of discussing each and every case with Madam wherever she is in the world. She is actually, and I would request another dynamic and a personality from Meerut who has brought Meerut to the level of National Foxy, our Vice President, Dr. Bharti Maheshwari, to please begin the meeting with her welcome address.
Thank you, Priyanka. So as we really, Meerut Society, welcome all of you in this meeting on the recurrent pregnancy loss by Human Biologicals and Meerut Society. And as we are really fortunate that today we could have this meeting, and we have a speaker, Dr. Rishikesh Pai, who is known not only for his academic excellence, but our Dr. Sharma madam has said that he's a very good human being and very approachable. And anyone who is doing practice of infertility in India, I don't think he, in any form he has not remained in touch of him. So really we are blessed, and today's topic is also very interesting. So without doing any delay, I request Priyanka that please go for the next session. Welcome you all.
Thank you, ma'am. Thank you, ma'am, for your blessings. Now we begin with the first session, which is a lecture by none other than Dr. Rishikesh Pai sir. And to chair the session, I would request two eminent ladies from Meerut, Professor Dr. Rukma Idnani madam, who is always known as teachers of teachers. Madam has taught us like practically, theoretically, day in, day out, in every form. And she's like a godmother to all of us, actually. We also have Dr. Manjula Lakhanpal ma'am, who is a very senior gynecologist from Meerut, our past president, to chair the session. I would request Dr. Rukma Idnani madam to please introduce Dr. Rishikesh Pai sir.
Dr. Rukma Idnani ma'am, kindly unmute yourself. You're muted, ma'am.
Rukma, introduce karo.
Am I audible?
Yes, ma'am.
Good evening, everybody. Respected Dr. Sharma and the other office bearer, I'm really honored to introduce Dr. Rishikesh Pai, who is a very dynamic and eminent personality in our Foxy. And we usually call him as a Krishan Kanhaiya, all the gopis around her when he comes in the meeting. So we all just want to talk to him. So I will introduce Dr. Rishikesh Pai. There are so many words about him, but I will read out the important ones. He is an administrator Foxy Manyata Project with MSD for Mothers and MacArthur Foundation, Jepaigo. He is a director and corporate director of Corporate Affairs, International Federation of Fertility Society. He is an honorary consultant on postgraduate teacher in DNB examination, Leelavati Hospital, from 2007 till date. He is a visiting professor in the obstetrics and gynecology of Manipal Medical College. He is on the editorial board of International Surveillance Global Health from 2019 to 2020. He has been a member of International Advisory Board, IVF Worldwide. He is a chairman Health Promotion Society. He is a medical director of Bloom IVF Group and consultant of IVF specialist at Leelavati Hospital, Mumbai, DY Hospital Medical College, Navi Mumbai. He has been a consultant as IVF specialist at Fortis Hospital, New Delhi, Gurugram, Faridabad, Mohali, and Vashi. He is a recipient of the 45 awards. Some of them are being honorary of RCOG. Number 2, receiving this medal, this award he has been received in the RCOG London 2019. Is our late Prabha Malhotra Lifetime Achievement Award in Hyderabad 2020. Shri Shyam Satyapal Chairman Award, New Delhi 2020. Foxy Shiromani Award, AICOG Lucknow 2020. Is a Foxy Chairman of Motherhood Award, Lucknow 2020. Lifetime Award for Outstanding Research in the Reproductive Health by ISSRF New Delhi 2019. Has been published 28 papers in national and international journals, edited 16 books. He has delivered 20 plus orations, invited speaker, chairperson, and has been a panelist of 100 national and international conference 1991. Thank you, Dr. Pai. With these words, I introduce you in our society and welcome you in the Merit and Obstetrical Society. Thank you.
Thank you, madam. Thanks a lot for the introduction. Can I just allow me to share the screen? Yeah,
Yes.
I'll just share the screen. Okay, so I'll be talking today on recurrent pregnancy loss. And what I've done is that I'll just talk about the first part, that is the etiology part. And the management part, we'll have a discussion and interactive session amongst all the 4 panelists. Can you hear me, madam?
Yes,
yes. Yeah. Okay,
Yes.
so the initial part will be the discussion of the etiology. So if you look at recurrent miscarriages, the loss of 3 or more consecutive pregnancies, including biochemical, till 24 weeks. This is the RCOG definition. While the ASRM, that is the American Society of Reproductive Medicine, they define it as the loss of 2 or more clinical pregnancies, but in this, they don't consider the biochemical pregnancy in the calculation. And of course, you can also further classify it into primary, secondary, and tertiary RPL. Primary RPL refers to multiple losses in women with no previous viable infants. Secondary RPL refers to multiple losses in a woman who has already had a pregnancy beyond 20 weeks of gestation. And tertiary RPL refers to multiple pregnancy loss between normal pregnancies. So if you look at the basic facts, I would like to say that the etiology classification I have done based on the ASRM. So, you have to have some definitive etiology on which you need to create the algorithm. And the algorithm is based on the practice committee report of the American Society of Reproductive Medicine, which was published in Fertility Sterility in 2012. They have not come out with a new guideline. And They have classified the etiology into two parts: explained etiology and unexplained etiology. Explained etiology is in 50% of the cases, and in that the parental chromosomal abnormality is around 5%, contributes to the etiology. Autoimmune disease, especially the APLA syndrome, 15%. Uterine structural defects such as septum or a submucous fibroid, 12%. Endocrinological problems such as hyperprolactinemia, hypothyroidism, or diabetes, that is 17 to 20%. Luteal phase defect or PCOS related RPL. And then others which are infection, which is 0.5 to 1.5%. Male factor can be a contributory factor, psychological, alloimmune causes, environmental, occupational, and personal habits. So this would cover about 50% of etiology. The remaining 50% has no etiology and it is called unexplained. But recently there was a paper by Popescu in Human Reproduction in 2018, where she analyzed 100 recurrent pregnancy loss patients, their abortus. So in 50% of them, she could use the ASRM classification and quantify them as explained causes. But in 50%, where she could not put a cause to it, she analyzed all the aborted fetuses using the advanced new technology of microarray. So the normal analysis of the karyotype is done for products of conceptors, but that's a standard method, and many times because the products of conceptors are not alive, it's a dead tissue, they don't culture, or many times you may culture the mother's tissue rather than the fetal tissue and you may get a wrong report. So if you have a CGH microarray technology, based on that, she could show that out of this 50% unexplained, actually 45% had abnormal products of conceptors, which were normal on karyotyping. But when the CGH microarray was applied, there was a lot of abnormality in them. 45, only 5% after this test was applied, only in 5% they could not pinpoint a cause. And maybe these 5% were the immunological causes of miscarriage. So the conceptually, nearly 95% of the miscarriages can be explained based on genetic or non-genetic, and only 5% you may not have an explanation, and maybe you can quantify or classify them as immunological etiology. So there are additional etiologies which have been suggested by the practice committee of the American Society in 2012, but they are not to be considered in doing the primary workup. You may do it for research purpose. Professors may ask their students to do analysis, do research paper writing on it, but they are not. So some of them are analysis of IgG or IgM, anti-annexin A5 antibodies, anti-factor 12, anti-prothrombin time, IgA, ANA, anti-thyroid antibodies, anatomic test for cervical. Cervical, when we talk about miscarriages, we don't want to talk about the second trimester miscarriage, which is due to incompetent cervical loss. That's a totally separate topic. So when I'm talking, I'm not talking about that part. I'm mainly focusing my talk on miscarriages that occur before the 12 weeks of pregnancy, the traditional miscarriage. Hormonal problems like PCOD, insulin resistance, fasting insulin, luteal phase defect, day 21 progesterone, all these are additional add-on tests you may do, but they are not utilized for standard analysis. Bacterial vaginosis, endocervical infections, you can do see whether there's a semen abnormality, semen test you can do, sperm DNA fragmentation, you can do psychological testing, and there are a lot of alloimmune for testing immunological etiology. There are a lot of tests which are available like mucosal CD16 NK cell levels, amylotoxic factor analysis, cytokine profiles, blocking antibodies, HLA typing, anti-paternal leukocyte antibody, circulating CD16 NK cells. All these are there, but they are all experimental. If you look at the genetic cause, the maternal age is the biggest contributor of genetic problem. The background risk of having 3 miscarriages for women less than 25 years of age is around 0.13%, but increases 100 times to 13% if the age of the woman is above 40. And given the impact of female age on embryonic aneuploidy, aneuploidy means trisomy, trisomy 18, 21, that they are all called aneuploidies. The rate limiting risk factor for miscarriage in older women is not treatable. Now, how can you reverse the age of a woman? The only way of doing it is that freezing your egg before the age of 35. And then when you have a child at the age of 40, using the frozen egg. That's the only way you can reduce the miscarriage at that age. So if you look at the genetic causes, so how does genetic abnormality occur? It's the three ways it can occur. One is that genetic abnormality can be inherited from a parent. So one of the parent may have a balanced chromosome, like a reciprocal or a Robertsonian translocation. So there is a problem in her chromosome. However, she is normal because it's balanced, but that chromosome can be transmitted by her to her embryo, and that may cause a genetic abnormality on a recurrent basis, and that may cause abortion. So that is very important to understand. And so we need to do karyotyping, which can pick up reciprocal or Robertsonian translocation. But there are a lot of other detailed abnormalities, like you have got X activation, chromosome activation, etc. These need very advanced SNP repeat analysis of the father or the mother, and these are still in the experimental phase, and we can't really interpret them well. But balanced you can always do a karyotype. See, abroad they don't do karyotyping because it's a costly test. So only if the aborted fetus is abnormal, then they will do a karyotyping. But in India, it's a cheap test, so we can do karyotyping on the mother and father just like a routine test. So it is okay, but abroad it is not possible. So this is one of the contributory causes. The other cause, so by testing the products of conceptor, so as soon as you can test the product of conceptor when there's a first miscarriage. So a first miscarriage is normally a sporadic miscarriage. Chalo, aise ho gaya. But the second abortion, you must start testing, because nowadays you can't wait for 3 abortions. So immediately the second abortion comes, you must test. And I would advise that all of you should now test for microarray. You can't test because this is a very important test, because if the aborted fetus tests for positive for a chromosome abnormality, that means that the maternal factors are ruled out. So a maternal hyperprolactinemia or a Apla syndrome is automatically ruled out. So conceptus testing, but accurate. You can't do karyotyping now. In this day and age, you can't do a karyotyping. It's totally, you'll get a wrong report. You have to do either a microarray test or you have to do a NGS test on the aborted fetus, and it is not very costly, 10,000-15,000 rupees. But if suppose a patient is going to have a problem, and this test is going to become cheaper and cheaper as now a lot of new DNA labs have come. So this is very important to test. Coming to the immunological causes, so one is a big problem, which is Rh isoimmunization, which is a big topic by itself. So, but that is that also can have damage, and the babies don't sustain. But that can be easily done by, in an Rh negative woman, you just do a test of antibodies and you know whether she's isoimmunized. So I'll not really talk about it. The other is the autoimmune disorder. So there are a lot of autoimmune, nearly 20 clinical autoimmune disorders are there. Of the common of them are Apla syndrome, lupus, anti-nuclear antibodies, and antithyroid. There are this, lupus is there, or Apla syndrome, which are commonly seen as autoimmune. And then we have alloimmune disorders. So if you look at the thrombophilia refer to an increased risk of developing venous thromboembolism. So all these thrombophilia, there is a high chance of developing deep venous or superficial venous thrombosis, and they can be acquired or inherited. So they can be congenitally inherited through chromosome, or they can be acquired, such as Apla syndrome is a acquired thrombophilia, while a factor V Leiden mutation is a inherited thrombophilia. So acquired antiphospholipid antibodies are thought to impair pregnancy through various mechanisms, including inhibition of tropoplastic function, thrombosis of uteroplacental vasculature, and initiation of a local inflammatory response at the maternal fetal interface. While inherited thrombophilias include hereditary conditions such as factor V Leiden mutation, prothrombin gene mutation, protein C deficiency, protein S deficiency, antithrombin deficiency, and their relationship with early fetal loss is very not clear. So most of the time people feel that inherited thrombophilias don't really contribute to RPL, while yes, acquired thrombophilias do contribute to RPL. And Apla syndrome is a topic by itself. I'll not go into it, but it is characterized by one clinical and one lab criteria. So the clinical criteria is one or more confirmed episodes of vascular thrombosis or a pregnancy complication, including either 3 or more consecutive pregnancy losses at less than 10 weeks of gestation, 1 or more fetal deaths at greater than 10 weeks of gestation, or at least 1 preterm birth due to severe PIH or placental insufficiency. So you need to have a one clinical criteria and you need a one lab criteria. So laboratory criteria has to be repeated at least 2 times more than 12 weeks apart. And the 3 antibodies which they test for is anti-cardiolipin antibody, IgG or IgM, anti-beta-2 glycoprotein 1 antibody, IgG or IgM, and lupus anticoagulant. And this is where the problem arises, because our after our COVID experience, I just yesterday I had one of my friend's father tested positive first day, then they repeated after 24 hours, tested negative, then they again repeated after 24 hours, again tested positive. So the laboratory, I always feel that the laboratory medicine in our country needs to be really improved. And so this is very important. If you have a bad laboratory, you are going to miss the diagnosis of Apla syndrome. And many of the time when we do empirical treatment of recurrent abortion by giving them heparin, we are actually treating Apla syndrome, which have been missed by the laboratory. And that's why we get a good outcome. So if you look at the Apla test, the lupus anticoagulant. So the guidelines have been given by the American Society how to do the Apla test, and these are the guidelines that when you do a lupus anticoagulant, serum levels of lupus anticoagulant are evaluated using the dilute Brussels viper venom test, and the PTTA-LA results greater than 42 that were not corrected with a 1.1 mixed with normal serum are considered abnormal if confirmed by a hexagonal phase phospholipid test. So this is a proper guideline, anti-cardiolipin and anti-beta-2 glycoprotein. How to exactly test this is very important. So this is as far as the Apla is concerned. So first contribution is by genetics, second is by the inherited hemophilias, that is Apla, and then comes the Mullerian defects. So the overall incidence of Mullerian defects is 5%, and in infertile women 3%. Recurrent spontaneous abortion, the incidence is 5 to 10%. And a second, third trimester preterm birth, the incidence is 25%. If you look at the uterine factors, they can be acquired or congenital anomalies. Acquired ones are like polyps, fibroids, and there is a consensus that submucous fibroid, stage 0, stage 1, stage 2 of the European classification, FIGO classification, or any fibroid that distort the cavity needs to be. So if a intramural fibroid is there, which is pushing the cavity and distorting the cavity, yes, that also needs to be removed. And many people are of the opinion that an intramural fibroid, even more than 4 centimeters, or an intramural fibroid which is less than 1 centimeter away from the endometrial cavity, the distance between the fibroid and the endometrial cavity less than 1 centimeter can influence the expression of various HOX-A genes in the endometrium and cause miscarriages and decrease in implantation. And many people feel that intramural fibroid of more than 4 centimeters should be removed, but that's controversial. Submucous fibroid definitely should be removed. However, there are a lot of RCTs that have not proven 100% that submucous fibroid removal will improve RPL. But everyone assumes that any polyp, or there are a lot of RCTs about polyps also, that even if you leave a polyp inside, it doesn't really affect the outcome. So however, now it is accepted that any polyp or a fibroid, definitely it should be removed. What about anatomy defects and how do you diagnose them? So it is very important, and this is where I would like to emphasize now that 3D ultrasound and sonohistography is very important. Nowadays, in infertility diagnosis, you must do a 3D ultrasound. So you later on, while doing IVF, etc., you may do a 2D ultrasound, that's okay. But the primary diagnosis, the first time diagnosis of a patient of infertility or RPL, you must subject her to a 3D and preferably a sonohistography, because the internal cavity also can be delineated along with the 3D ultrasound. And this is very important. And especially I would like to say at this stage that a lot of people do resection of the lateral wall of the uterus. So in the new classification has come where by 3D ultrasound, you can actually differentiate between infantile uterus and a T-shaped uterus. So a T-shaped uterus, you should do lateral metroplasty, but in an infantile uterus, you should not do a lateral metroplasty. Both of them will look the same on a 2D ultrasound, and the only way you can differentiate an infantile uterus from a T-shaped uterus is by doing a 3D ultrasound. Similarly, if there has to be a differentiation between the arcuate uterus and the septate uterus. So the distance between there's an imaginary line between the two cornua, and the distance, if it is less than 1 centimeter between the imaginary line and the leading part of the septum, it is known as an arcuate uterus, while if the distance is more than 1 to 1.5 centimeter, it is known as a septate uterus. So this classification is very important, because the indication of cutting a septum is only for a septate uterus and not for a arcuate uterus. Because there was one of my friends who had one of the patients complained against him, and he was such a leading professor abroad. He lost his job because they had an internal investigation, and they said that you were doing surgery on arcuate uteruses, which is not indicated, and that's why they removed him as a professor from one of the leading colleges abroad. So it's very important to not just blindly operate, because litigation is increasing drastically. So ultrasound, 3D ultrasound, you can see here bicornate uterus is there. Septate uterus. This is a septum, and both of them look the same. So the gold standard would be, of course, a laparohysteroscopy, but a 3D ultrasound in combination with sonohistography can make a difference between a bicornate and a septate uterus as well. And a 3D ultrasound can differentiate between a septate and a arcuate uterus, which is very important, and not to touch a arcuate uterus, only touch a septate uterus. Thyroid antibodies and thyroid hypothyroidism also can cause miscarriage, and the cutoff level is 2.5, not 5. So more than 2.5 MIU per ml of TSH would be a cutoff level for diagnosing thyroid. And there are other things like selenium deficiency, which can be associated with impaired beta cell immunity, which can manifest as miscarriage. There can be vitamin D3 deficiency, many people feel is manifesting as recurrent pregnancy loss, and you can anyway test, but these are, as I told you, not indicated testing as far as the ESRM is concerned. You can do it as an experimental testing, but not. Another area of hormones is the hyperprolactinemia, and PRL more than 23.3 nanograms per ml is very important to come to a diagnosis of RPL, contribution to RPL, or a diabetes mellitus. HbA1c of more than 6.4, maybe more than 7 would indicate a poorly controlled diabetes. You can do a proper glucose tolerance test and establish that there is a baseline diabetes mellitus which is causing recurrent pregnancy loss, and treat it as well. Or we can look for PCOD, and the confirmation of PCOD nowadays best would be, of course, use the criteria, and mainly the ultrasound picture of AFC more than 20 on both sides of the ovary, along with hirsutism and signs of anovulation, would contribute to the diagnosis of PCOD. And an AMH level of more than 4, nowadays 3.54, more than that, it definitely is a PCOS patient. Or a luteal phase defect. Normally it's very difficult to diagnose a luteal phase defect, but you can do a day 21 progesterone on, and if it is less than 10 nanograms per ml, we know that it can be a luteal phase defect that is contributing to the recurrent pregnancy loss. Endometriosis and adenomyosis is also contributing, and recently I was just telling you that there's a new 5 articles have come in fertility sterility, and one of the articles is on endometriosis and adenomyosis, and it can cause RPL. And endometriosis, I've just added these few lines from the fertility sterility, that it can cause by alteration of oocytes and embryos because of the toxic products of the endometriosis. The oocyte and embryo quality can be altered, and that can result in RPL, or it can cause inflammation, and this inflammation can mediate histological changes in the endometrium, which can cause RPL. Adenomyosis, they are saying that inflammation in the endometrium can be there, uterine contractility can be affected, and that can cause abnormal peristalsis, and abnormal implantation is also there in the terms of implantation of the trophoblast invasion into the layer of the uterine cavity. there is no one single therapeutic approach, but what they have found that frozen embryo transfer with euploid blastocyst can cover all these things. And normally I would suggest that if there is an endometriosis or an adenomyosis, or 2 GnRH agonist shots. So you do an IVF, freeze the embryo, give 2 GnRH agonist shots, and then transfer the embryo into the cavity, and that really improves the outcome in endometriosis and adenomyosis. Male factor also contributes, because of male factor, if a sperm is not good quality, then the resultant embryo may be genetically abnormal, and that can cause RPL. And so it is very important to look for proper semen analysis. And there is a trend towards repeated miscarriages with abnormal sperm, where normal forms are less than 4%. And there is a higher incidence of sperm chromosome aneuploidy seen on. You can do a new test that is called sperm fish you can do. And this sperm fish technique, if it shows a lot of aneuploidies in the sperm, that can be a contributory factor for miscarriage. So looking at sperm motility, viability, and various sperm function tests can be done. But the most important test, which has been in now a lot of attraction and is the sperm DNA fragmentation test. And if there are, based on this systemic review of TAN, Italian RBM and non in 2019, the association between sperm DNA fragmentation and idiopathic RPL, their results demonstrate an overall strong association between the high levels of sperm fragmentation and RPL using both the tunnel and the SCD assays. As genetic abnormalities are thought to contribute to early miscarriage, our findings support the notion of a possible paternally derived genetic origin of recurrent unexplained pregnancy loss. Infections are also, and this is a very interesting thing. Just a new article has come, and just now I picked it up. Just about 20 minutes back, I picked up this new. So chronic endometritis is very important, and you can, of course, diagnose it by histopathology, but hysteroscopic findings of focal or diffuse hyperemia, polyploidal endometrium, and micropolyps, small 2 millimeter polyps, that are indicative of endometritis. So a visual diagnosis of endometritis is very important. And of course, a histopathology, immunohistochemistry diagnosis of CD138 plus if plasma cells, if there are more than 5 plasma cells in 20 to 30 high power fields, that is indicative of endometritis. And the treatment is ofloxacillin with metronidazole or doxycycline for 21 days. And there are new tests that are coming in where you can take a biopsy and you can do microarray technology. Using a microarray technology, you can find out the level of what is the infection level, and these are some of the organisms that are implicated, like ureaplasm, urolacticum, mycoplasma hominis, chlamydia, monocytogenesis, listeria, toxoplasmic gonadai, rubella, cytomegalovirus, herpes, and other less frequent pathogens have been identified more frequently in vaginal and cervical cultures, and serum from women with sporadic miscarriages are seen to have these things. So there is no convincing data as such, but you can, when you're doing the workup or when you're treating them, you can give a course of doxycycline for 21 days or a ofloxacillin in combination with metronidazole, and later on try the treatment. I also give a lot of these people, I give them probiotics to cover the good, the vagina and the internal milieu of it by lactobacillus, and I give them a lot of lactobacillus supplementation as well. Poor ovarian reserve also can contribute to poor quality and quantity of oocytes and increased incidence of abnormalities in the oocytes, and this in turn can cause an abnormal embryo and can manifest as repeated miscarriage. There are other miscellaneous contributory conditions which can be investigated, but they are not definitive, like environmental chemicals and stress. Anesthetic gases are known for like nitrous oxide, formaldehyde, pesticide, lead, mercury can cause sporadic losses, but not normally. RPL is not in. Personal habits like obesity, smoking, alcohol, caffeine their association with RPL is not clear as such, but may act in a dose-dependent fashion or synergistically to increase the sporadic pregnancy loss. Exercise does not increase sporadic or RPL, and hyperhomocystinemia is also implicated, and many people advise taking a heavy dose of folic acid, DHA, vitamin B6 and B12. Congenital thrombophilia, as I said, for the present is not recommended that RM patient be routinely screened for congenital thrombophilia because it's not really connected as such. So that comes to unexplained. So once all these tests are done, about 45 to 50% of patients, we don't find any cause. But as I told you that this landmark study by Popescu was done in 2018, and she found that if you really analyze these about products of conceptors using a microarray technology rather than a standard concept karyotyping technology, nearly 45% you can do pickup. So of these 50% unexplained, 45% of them are due to actually malformations and aneuploidies which you have not picked up in karyotyping. So the problem of unexplained RPL, the first is that there are, so what is the problem of unexplained RPL? First is that there is an alarming paucity of moderate and not so strong number of randomized controlled studies, which can almost be counted on one hand. Second is that in the absence of strong or moderate level evidence, expert clinicians have widely differing views on how to straddle that great divide between evidence-based recommendations and the need for real-world patient care. Evidence-based medicine without evidence is a challenge. Although relevant data may be lacking or inconclusive, clinicians must still address and discuss the therapeutic options with their patient, presenting the theoretical basis for an intervention and weighing the risk and benefits with the patient is a reasonable compromise. You have to tell the patient, listen, we don't have much information. You are unexplained cause. We have not been able to make out what the hell the cause is. But and if risks are there, including both medical and financial, are minimal, the potential benefit unproven, the patient may choose to pursue a low-risk intervention. Like you can give them corticosteroid, you can give them HCQ can give them. So all these can be, hydroxychloroquine can be given. So all these are not very costly interventions and they are not that harmful interventions. So they can be given after explaining to the patient. So autoimmune causes are a variegated etiology. See, we are clubbing them together. So whenever you do the study and the outcome comes as, there is no statistical significance in the outcome, because they are actually a group of number of different etiologies which we have clubbed together. So in the future, we will have to sub-classify these etiologies, and then we need to do proper treatment or targeted treatment of different etiologies with different treatment. At present, the grouping is together. That is why the outcomes are not statistically significant. So there are different etiologies like close histocompatibility between partners causing improper immune response, lack of antipaternal HLA lymphocytotoxic antibodies, absence of circulating blocking factors which result in maternal lymphocytes attacking the conceptors, increase in natural killer cell activity of more than 18%, increase in T1 lymphocyte as compared to T2 lymphocytes. So these are all different etiologies. We are classifying them together, which should not be done. These etiologies need to different treatment. The treatment outcome need to be studied separately and not clubbed together. So next 20 years or 10, 15 years, research will be, there was a lovely article I read about 1.5 years back in Fertility Solidity where this was totally discussed, and the research will be to subclassify these etiologies and then target them with different therapies. So if you look at the role of progesterone, we all know this chart, as Dr. Usha Sharma, our great doyen, has said that there are multiple articles that have been given on recurrent pregnancy loss, and I don't want to go into the same thing, but basically it is a immune tolerance. So the fetus is not rejected by the mother, which is something which is a great phenomena in itself. You just imagine everything else you put anywhere, the body will reject it, except the fetus, the body doesn't reject it. So we still don't know what is happening at the level of the trophoblast, but there's a beautiful article that I read 3 days back, which is based on the uterine natural killer cell 1, its interaction. So that is the main cell which is there on the mother's side, and there is a HLA-C expression of antigen of the trophoblast, and their interaction with each other, which results in immune tolerance and doesn't reject in the rejection of the pregnancy. So these are all important interactions which need to be studied in the future. So the immunological causes are diagnosed by exclusion. So because if you say that you look at anti-nuclear antibodies, lymphocyte cross, these are all new tests that have come, multiple tests. But the commonest one is ANA, which is done. But there are other tests also you can do. But mainly, if you don't have access to this test, If all this is normal, then it may be a immunological cause. So you have a normal parental karyotype, normal HbA1c, normal cavity on HHG or histoscopy or 3D ultrasound, normal thyroid function, normal serum prolactin, no APLA syndrome, and maybe if you can do additional tests like thyroid antibodies, anti-nuclear antibodies, there is no aneuploidy in the product of conceptors on microarray NGS, and all this is normal, so it may be a immunological cause of infertility. So the diagnosis of immunology is a diagnosis by exclusion. However, just recently new technologies are coming in, and this is a very important 4 number I have added. This is the latest, just come out of the books, and this is a killer immunoglobulin like receptor. It is called KIR expression, and this is expressed on the uterine natural killer cell 1 and fetal human leukocyte antigen HLA-C, which is expressed on the extravillous trophoblast. It is called EVT. These two interact with each other, and their interaction is causing the recurrent pregnancy loss in immunological patient. And now there are various assays that are being done to analyze these levels, and based on these we can maybe quantify the immunological causes by doing a test in the future. See, we need to do a test. There is no test. The only test that is available is the ANA test at present, which is normally the prevalence of a positive ANA test in the general population is significant, 20%. A persistent moderate high titer of 1 in 60 positive ANA test is more likely to represent a manifestation of serological autoimmunity. In the presence of clinical disease, it is often accompanied by other more specific autoantibodies such as APLA syndrome or anti-double stranded DNA or anti-ROS SSA or anti-LA SSB antibody. And subgroup analysis has demonstrated that low titers of ANA, that is 1 in 80, were not associated with RPL, while higher ANA titer of 1 in 160 showed a significant association between ANA and RPL. So ANA tests 1 in 160 may be, and a lot of people are saying they may be an autoimmune group of disorders may not be manifested at the point in which you did the ANA, but 10 years down the line, these will develop into full-blown autoimmune disorders, and maybe you can pick it up, and in the earlier phase of their career, their life, that particular woman may manifest as a RPL, but it's because she's still in the subclinical phase of the autoimmune disorder. So I can't get this. Until randomized studies are in place and are available for 2 patients for enrollment or results are reported to guide therapy, balanced discussion of empiric low-risk therapy with low-dose aspirin, low-dose glucocorticoid, or HCQ, hydroxychloroquine, may be reasonable for presumed autoimmune mechanism in individual situations with moderate to high titers of ANA positive patients. In conjunction with compassionate counseling, these may maximize potential benefit and minimize risk. So if you there is in abroad or all over the world, a lot of immunologists treat recurrent pregnancy loss, and the immunologist will use glucocorticoid, hydroxychloroquine, aspirin more aggressively. See, the gynecologists are not, they don't use it that way. The immunologists, so there is a different approach to this thing. So now this is where I want to end my discussion, because this is now where we start now talking, and so we are going to now start discussing the treatment, and this is where we are going to discuss with each other the treatment. So we have now come to a phase. So before I start the discussion, I would like to first and foremost, because I started the talk and I didn't acknowledge the Dr. Usha Sharma is like my, I feel that she's like the president only of Foxy, and we will all come and go, but madam is going to stay and be respected by all of us, and I'm really grateful to be there today in her presence. And I'm thankful to our president also, Dr. Kirti Dubey, who has got up and she's listening to us all the way from USA. And Dr. Bharti Maheshwari, our very active Foxy and MTB chair committee, now ultimately will become vice president, I'm sure, from the north at some point in time.
God bless.
And then Dr. Priyanka Gar, who is the secretary at present, and Dr. Anju Rastogi, the joint secretary, and of course my favorite Chair Dr. Rukma Indani is there, my very favorite lady, and Dr. Manjuta Lakhanpal, our chairman, who is there. So we are now going to I would like to thank you and acknowledge you also. I just went through the etiologies of it, because knowing the etiology is like the half battle is won. Now we need to treat the etiologies one by one. And it's so as I told you, 50% is very easy, because we will pick up, Acha, she has got diabetes, she has got prolactin is more, she has got thyroid is high. So these are easy to pick up and treat. So let us now go to the first is the genetic causes. So if you are looking at genetic causes, so I think I'll start with Bharti, because genetics and all, Bharti is into IVF and all that. So what would be the indication? So how would you treat? Suppose a patient is there and we did a testing and we found that she has got a balanced translocation. The wife has got a, let's say, a balanced translocation. Then what would you counsel her? What would you do for her? How would you treat her in this case?
Dr. Pai, as you have already told, that first of all, it's a really very informative lecture. Your lectures is very informative. We got a lot of things. Now, as you are asking that, you already told that in the recurrent abortions, around 5% the incidence could be genetic. But as a patient comes to us and if she is having the history of RPL, recurrent pregnancy loss, as by the definition, of course, and if she's a early trimester pregnancies, the genetics are mainly before 10 weeks or before 8 weeks losses. And by history, we can find out many things. And most important thing is that is if we could have a abortus genetic examination. And nowadays, I think in 7-8 years before, we were not able to do. But now almost in every cases, awareness has been increased and we are able to do that by microarray. So if you are able to find out that whether this genetic material that she has are not able to continue having the translocations, or as you have told, that balance or a Betsonian, then you can advise accordingly. And one thing nowadays, NIPT is also sometimes we are using in the maternal blood. Then we are able to find out the chromosomal studies. And besides that, all of us are doing the karyotypings also. So the counselings, what I tell that regarding the genetic, we tell the patient that in the you have written this very important issues, but in the 50% cases, we have seen that they have a good reproductive outcomes in a coming year. But of course, if according to the reports of the if it is a translocations, a balanced translocation, and if it is only their carriers, then of course the chances that they have a lots of options. Either in the coming pregnancies, they can just go blindly with the whether they want to take a chance, or they have options that they can go for the prenatal genetic diagnosis for the coming pregnancies to know it before that what is they have. And even they have options for the even sometimes the gamete donations options also. In the IVF, they can choose that option. So these are the nowadays there are lots of options. And and you have showing this studies where you are showing that there is a very low risk of viable offspring with unbalanced chromosomal abnormalities in carrier couples. So most of which can be detected at prenatal diagnosis. So in these cases, the role of prenatal diagnosis is there. And of course, we all know that nowadays we can do the gametes biopsy, so we can find out that things. Yes,
right.
Dr.
So
Pai.
what you are saying is correct. So basically, you can do for pre-implantation genetic testing, but this particular study, they divided them into two parts. One, and they found that even if you leave them alone, ultimately these people will ultimately land up in a normal. Maybe they will have 3-4 miscarriages and then land up with a normal pregnancy. But so there are certain people will say, no, we can't wait for so. Nowadays our couples are more aggressive. In the olden days, Are Bhagwan karega. Madam, I would like to ask Dr. Usha Sharma. So, in your or Dr. Idnani, in your experience, just you leave them alone, do they ultimately land up with a child?
I think so. I think so, because, neither you can exactly diagnose it sometimes, and nor you have you can say direct or a correct treatment to these things. So I think we can advise them that let us wait and watch. Maybe Bhagwan ki kripa ho jaye aur aage. Because in 65% of the cases we have seen कि जिनके इतने रिकरेंट अबॉर्शंस होते हैं, उसके बावजूद भी they conceive and give birth to a baby. So,
Yeah, so
Dr.
I think
Rishikesh, I would like to add that even if the couple is carrying a balanced translocation or Robertsonian, we should counsel them that it is not that always all conceptives of hers are going to have a genetic, and there
Right.
are chances that she can have a normal child. So it is she who has to take the risk for going for a pre-implantation genetic diagnosis, or she wants to go for a natural conception and wants to go for a, instead of a pre-implantation, she can go for a prenatal genetic diagnosis. This we have to counsel her, and it is she who has to decide for it. But because we have to tell her that there are chances that she can have a normal baby, as Dr. Sharma says, that there are chances that people have given birth to normal children.
Plus, certain translocations are very high-risk translocations, like on 13 chromosome, 21 chromosome. So we need to address special care to these patients.
So
there
now,
are high-risk translocations actually.
So, you're right. So all of you are right. So the genetic counseling is very important for these people, and they have to be told that the overall live births have not shown to be very high. Suppose even if they do IVF PGTA, it is in compared to natural consumption, and this is a Murugappan's 2016. There's a new study that has come up. However, what these people are saying is that it remains possible that PGT in couples with structural chromosomal defect might reduce the number of miscarriages experienced prior to a successful live birth, decrease the time taken to pregnancy, and decrease the emotional stress and uncertainty for a patient till a positive pregnancy is achieved. But as you said, we can just be conservative. They can go for a pregnancy, and if by chance they cross that 10-11 weeks, then using a NIPT, and now there is a non-invasive prenatal test, so you can just collect the blood and you can do the test rather than doing any chorion villus sampling and all. So using an NIPT, you can rule out the major, see the three major aneuploidies that are there is chromosome 18, 21 and 30. So these are being now can be picked up easily by the non-invasive prenatal test. So you have to just do that test and you can easily make out. So that's one way of doing it. Okay, just try for a pregnancy once you cross it. And yes, you as anyway when these people are trying, we will supplement them with progesterone, HCG, and you can give them steroid and all these things which we'll discuss now. So with all that we don't have to give PGT as but a high order. So for 5-6 times miscarriage. Recently I had a patient with 8 miscarriages. I did the pre-implantation. I got 9 blastocysts. I've tested them all. There's 5 were genetically normal. I put the blastocysts and again she became pregnant and she has again landed up with a miscarriage. So despite of doing all these things also, and I see that, madam, in my experience, if you put it in a surrogate, they will go to top. So there is definitely, majority people say that it is a genetic embryo related, but there is definitely a uterine factor which is at play. And I have seen this happen many times. Recurrent pregnancy loss, you put it in a surrogate, they'll become pregnant immediately. So there is a that thing.
It has been studied in quite many cases even.
So when we are
In
talking
the surrogate
PGD,
mother, it is very successful.
Right.
So when we are talking of PGD at this moment, sir, does gene therapy or something help if we find an embryo which is actually having some abnormalities?
That is a future, though the lot of.
Sir, I had heard in your lecture only last.
A lot of study now research papers are there where we can modify the genes in the embryo using a CRISPR technique. In fact, this year only the Dr. Jennifer Doudna and Emmanuel Charpentier got the Nobel Prize for chemistry for CRISPR, and it is the shortest. 2014 they invented it, and 2016 I attended a training program in CRISPR in Delhi only, and in 2020 they have got the Nobel Prize. So coming to the next one is the anatomical, which is more comfortable for us gynecologists. We are happy when there is an anatomical problem because we can operate and correct it. So in the anatomical problem, suppose there is a fibroid, what is your opinion? Should we remove it? Suppose there is a question fibroid.
Okay, if it is,
I mean, I would like to any one of you. So all of you are there. Anyone can take the question. Nisha is there. Anju.
Submucous, can I answer, Dr. Rishikesh?
Yeah, sure.
Okay. So submucous fibroids should be removed, whatever may be the size. All polyps, and as we have talked of that there could be multiple small polyps, they also should be removed. And we know about septum resection, that this increases the pregnancy outcome to somewhere around about 80-85%. And myomectomy, if it's intramural, as you said, that it is more than 4 centimeters or 5 centimeters, it has to be removed. And this improves the pregnancy rate from 57 to 93%, it's reported. So
Okay.
that was as regards the myomas. The other anomalies in the uterus, like besides septum and myomas, there could be adhesions which have ended up into an Asherman syndrome, which would lead to decreased vascularity and improper implantation. And so this also has to be treated, and when treated, it gives good results. And we're not talking of cervical lacerations and incompetence, because that goes for second trimester abortion. We would restrict ourselves to first trimester. So if uterine anomalies are treated, they do give good results.
Right. So I think that, overall consensus that though the RCTs have not definitely proven, but overall ASRM has now shown in fertility study 2017 that until better quality evidence emerges, the ASRM proposes that it is reasonable to undertake surgical correction in cases of uterine cavity defects associated with fibroids, polyps, and adhesions. So this is 100%. We are all on the same page. Only as I told you that we have to be very careful of classifying the arcuate uterus from and we should not be done as a Ram Bharose. You have to classify it by 3D ultrasound, properly classified, and say, acha, this is arcuate based on the proper measurement from the intercornual line, and then looking at the distance, and then say, okay, this is more than 1.5 centimeter or 1 centimeter, I'm going to operate and cut it. Or this is less than 1 centimeter, I'm not going to touch it. Because, this is where litigation can occur in the future, because some patient will say, oh, why did you cut it? Then, someone may land with a rupture uterus later on. Why did you cut it? What was the reason for you cut it? So you have to be very careful. You can't be casual. Those days of casualness are gone now. Our patient don't look at us in that, in a generous way. So coming to the next cause is autoimmune cause. Again,
actually, we are happy to have anatomical defect than to have genetic defect.
I know, I agree. So we are very happy with our anatomical defect and fibroids and all. Even cervical, I didn't want to have cervical
At
incompetence.
least you can think of doing something which is apparent.
So Dr. Nisha is there, I think, you can maybe take. So, the APLA syndrome is, I've already talked about it, that how to diagnose it, and also how would you treat it?
So this is most treatable condition, and we have got two options: low molecular weight heparin and low dose aspirin. Both of them are really working well. Pathological laboratory diagnosis are very suspicious all the time. Most of the time we are not finding positive results, but just going by history, if we have actually low molecular weight heparin and aspirin, we are definitely getting good results. So this is the condition where we are really getting good results.
So, but tell me, madam, because the literature is very controversial about whether to use the low molecular weight heparin or standard heparin, because they are saying that low molecular is not that effective as a standard heparin. So we are scared to use standard heparin. We are not. We are gynecologists. We are very comfortable with low molecular weight heparin and aspirin, because in our mind, safety is very important also. But having said that, effectiveness is also important. So would you, and this is a question to all of you, would you really go for a low molecular weight heparin or a heparin?
Sir,
for this particular patient?
Low molecular it's safe also. It's osteoporosis is less as compared to unfractioned heparin. So we are definitely
It's a low molecular weight heparin, but dosage of heparin also should not be less, like not using micro mini doses, like 40 milligram. We should go
40
with
to 80
this.
milligrams.
That is important. That for second, now we have
Dosage is
pens
important.
also, which can give the dosage according to the requirement of the patient. So for second trimester, third trimester, postnatal, we should go with those doses only.
So the timing and all, I'll not just, it's too detailed. So let's skip all that. So the only thing, risk is very important to know that in aspirin, there may be a third trimester closure of fetal ductus arteriosus, pulmonary hypertension, intracranial bleeding, and heparin, mainly osteopenia and thrombocytopenia. And there sometimes steroids are being used by APLA, but they are not recommended in the management of the APLA syndrome per se. So then let's come to the endocrinological problem. And the hypothyroid is a big thing. So would anyone, Bharti, would you like to talk about that? Would you, how would you treat them? What would be your cutoff, 2.5 or 5? And how would you treat thyroid and diabetes, prolactin mainly? What would be your treatment strategies for this?
Yes. I think Dr. Anju, you are left. You want to tell?
Yeah, definitely.
And Dr. Anju can take it. Dr. Anju, Dr. Anju Rastogi.
It's okay. It's okay, Dr. Pai. When we go to the endocrinal causes of recurrent pregnancy loss, the one and the most important is the hypothyroidism. Even not only the clinical hypothyroidism, even subclinical hypothyroidism may be the cause of recurrent pregnancy loss. And the cutoff values are taken as 2.5, not 4 or 5. Values above 2.5 have to be treated with small doses of thyroid hormone. Another important part when we talk about hypothyroidism is autoimmune thyroid antibodies like anti-TPO and anti-thyroglobulin. There are two school of thoughts. One says that patients with normal thyroid levels with positive anti-thyroid antibodies should be given micro doses of thyroid hormone, while the other school says that when thyroid levels are normal, we don't need to give any thyroid hormone, even if the anti-thyroid antibodies are present. But then whenever we have normal thyroid hormone and anti-TPO bodies present, we have to be very vigilant for off and on checkup for the thyroid hormone. And whenever the value goes below more than 2.5, we have to give thyroid hormone. Another important endocrinal cause is prolactin hormone, as you told, that levels about 23 is to be treated. And then third comes the diabetes, as you talked about. Diabetes, only if it is not controlled and HbA1c more than 6.4 or more than 7 could be the cause of recurrent pregnancy loss. Otherwise, generally, recurrent pregnancy loss is not caused by mildly elevated blood sugars. But yes, whenever patient is planning for pregnancy with recurrent pregnancy loss or any pregnancy otherwise, must be having normal sugar levels for at least 2 to 3 months before planning a pregnancy.
Okay, so what about the LPD and PCOD? So that we can complete
luteal phase defect is again very difficult to diagnose. The best is to check the interval between the LH surge and the timing of next menses. And the duration less than 13 days is considered as luteal phase defect. The measurement of progesterone hormone is not very informative because the levels fluctuate many a times. So duration of luteal phase is calculated, and wherever it is less than 13 days, it is treated best by giving any ovulating drug like letrozole or clomiphene citrate or gonadotrophins, because the luteal phase defect is due to a bad follicle, not a good performing follicle, leading to a bad, not good performing corpus luteum. So supplementing progesterone is not that important as giving a good follicle by giving clomiphene citrate or letrozole.
Okay.
And then coming to the next, polycystic ovarian disease. Although the literature says that patients having normal glucose levels and insulin levels don't need to give metformin in these patients, but my personal experience is that metformin has a very good role in recurrent pregnancy loss with having PCOD.
So now I wanted to ask you two controversial questions. This is for all of you. So like in a patient with RPL, would you blindly give them progesterone anyway? We all of them us give. So would everyone say, okay, We all
Practically
give.
we do give, but the evidence does not support this. You had this promise trial also.
We would be giving not as a LPD, we can give it as an immunomodulator.
Yeah, right. So that is coming later on. So I think I'll keep the question for later on. So as far as the PCOD is concerned, if the metformin is going on, would you continue it in the first 3 months of pregnancy, which is a commonly asked question. So we have to get your answer. What does a mirrored gynecologist feel about it?
So again, this is very controversial again, sir. The Diabetes Society of India says that it should not be given in the first trimester. But I think all of us gynecologists are using it in the first trimester also.
Right. So I think we need to come out with a consensus and, publish it. I think, Bharti, you must do all these things. So publication is very important for litigation purpose. Tomorrow we give metformin and a baby has some abnormality. After it is born, they'll say, "Arey, metformin aapne diya, aisa kaisa ye wo." So we'll have to have our guidelines. So we can say, okay, we had this guideline of the FOXY, which said that you can give it, and we have had no complications. So this is one of the things I want to do as a FOXY president, is publish these guidelines properly in short, so that we have no problem for litigation in the future. So coming to the unexplained infertility. So again, in unexplained, we have the two main causes. One is the alloimmune cause and genetic. I told you that if you do the test and use a CGH microarray to do the test, many of these aborted fetuses will be genetically abnormal. So it is a genetic origin, but it's not that clear cut, because a genetic abnormality can also elicit a alloimmune response. So it is all very interrelated, which is very difficult to, break up into two. But in the alloimmune causes, if you look at the treatment, as someone just now rightly said, that immunomodulation and potential, and there are a host of therapies that have been used, such as, of course, commonly we use progesterone, IVIG, infralipids, steroids, pattern and leukocyte immunization. Nowadays, some people are giving GCSF subcutaneously. And as I told you, a lot of immunologists abroad in USA, recurrent pregnancy loss is treated not by the gynecologist, but by the immunologists. And many of them, they give hydroxychloroquine also, which we use for our COVID. We used it a lot because it's given by them a lot also. And then we have the anti-inflammatory, like aspirin is there, heparin, steroids, and these are all empirically given. So this is where the progesterone therapy comes in. And I would like to ask one of you, if any one of you want to volunteer, what is your take on progesterone as an immunomodulator, what it does, and should we give it as a regular treatment blindly to everyone? Who would like to take this?
Sir, evidence doesn't support it, but yes, practically we are using it.
Okay.
It has been said that it increases blocking factor, it decreases natural killer cell, it also decreases cytokine response, pro-inflammatory response. So these things may support progesterone supplementation.
Change from TH1 to TH2, sir.
TH1 to
Yeah,
TH2.
all that, we have heard it so many times, all of us, that even if we are woken up in our sleep, we'll be able to tell it. But, like these are the studies, that 3 studies which showed that dydrogesterone is more effective than conservative management in enabling pregnancy. And this was a study by Sakon in 2017, which he concluded that women randomized to the progesterone group in the first trimester and before 16 weeks had a lower risk of RPL and a higher live birth compared with control group, where he had compared 10 randomized trials, and he compared the incidence of miscarriage in women with a history of RPL after treatment with progesterone in the first trimester of pregnancy, and was compared with the control group. So the interventions were natural progesterone, medroxy, cyclopentylenol, ether of progesterone, 7-hydroxyprogesterone, caprolate, and dydrogesterone. All these studies were clubbed together, and the conclusion was the promise, as one of you has said, the promise. Would like someone talk about the promise trial? Anyone of you would like to say anything about the promise trial? I'll just read it out, that the progesterone in recurrent miscarriage trial involved.
Promise trial doesn't support use of progesterogens in the
right. So, but there was a sub-analysis where a meta-analysis of 10 RCTs, including the promise trial. So the promise trial, anyone would like to say about the promise trial?
Yes, sir.
Please go ahead about the promise trial, please.
So this, the PROMISE trial, which was held recently, it said that, I think it was in 2016, it said that first trimester progesterone therapy in women with a history of unexplained recurrent miscarriages. It was a randomized, double-blind, placebo-controlled large trial. And they said that it was recommended by RCOG and Cochrane, actually, that progesterone therapy helps in RPL, I think. Like this.
Basically, sir, this trial they have compared the natural and synthetic progesterone in the different studies, and they have found that the they have found that natural progesterone may be beneficial, but it should be started in the luteal phase, and they have of course continued beyond the first trimester, at least 12 weeks till, or it should be continued. But it is not any definite thing that it is a definite incidence that progesterone is giving advantage. So that is this was
I think that is more or less summarizes it. So what about HCG? Because when we have a patient, we will do everything. We give progesterone. I've seen injectable progesterone, oral progesterone, HCG twice a week. So what is your opinion about HCG? Anyone can take this question.
Kirti ma'am would say about this.
Dr. Kirti?
HCG, I believe, does benefit to the patient, especially to those patients who, besides bringing about an ovulation, it is going to support the corpus luteum and bring about a good progesterone from the luteum. And because it promotes, it's said that some angiogenic activity in the endometrium is also promoted by HCG. So HCG is beneficial to patients of RPL and with added progesterone later on.
Okay, I think so. We do give HCG, but when we
but
don't
at times
know.
They say they are harmful also, because the placenta, basically the corpus luteum is not good. And once we are hammering with HCG, it will not result in producing more of progesterone. So rather than giving progesterone is a better choice rather than hammering the corpus luteum, actually.
Right. So, but we are having said that, theoretically, practically everyone even gives HCG twice a week. So what about methylprednisolone? So where can it be used? And are you, any one of you, using prednisolone or steroid in your practice? And if you are not using, what is the reason? What are the side effects we can have? Is there anyone who has so basically a lot of people are using steroid, but there is an increased risk of prematurity, orofacial clefts can be there, gestational diabetes, hypertension can be aggravated. Very rarely avascular necrosis of the femur head is also possible. I use it only when when the fetal heart is going down, when they come to me and they get admitted at around 7 weeks, fetal heart rate activity is around 90 beats per minute. And all, then I give them antibodies and I give methylprednisolone, because I learned to use the methylprednisolone from one of the biggest recurrent pregnancy loss experts in the world. His name is Dr. Sehata. He has got a very big clinic in UK. People from all over the world. He does treatment of nearly 3,000 to 4,000 patients a year. And when one of these patients many years back had come to me, and I saw him giving heparin. That's how I started using heparin in my practice. And he used to give methylprednisolone 25 milligrams. So there's a tablet 8 milligram available. So I used it, but I have sometimes had problems, and one of my patients has had landed with a avascular necrosis of the femur head also. So whenever you do something, there is always a side effect which you also have to tackle. IVIG
and
also
there
is
are
a big,
more apprehensions with
so we should not use it as a rule. As a rule, steroids we should avoid. So what about IVIG? Is there anyone who has got any experience in intravenous gamma globulins? And do you advocate it? Some Indians are using it because IVIG is not very costly in India. Abroad, it is cost 8,000-10,000 pounds and all that. But in India, IVIG therapy may cost 25,000-30,000 rupees. So what is their opinion? Anyone wants to talk about IVIG?
Sir, some patients from Delhi, my doctor's colleagues' friends, and they said that their relatives, they are using it when they are, treatment they are getting in the higher hospitals in the Delhi. I have experienced in some other colleagues' patients of the IV immunoglobulin, but as a literature, as in my impressions and what I could study is that there are no as such clear evidence of the advantage of IV immunoglobulin. But now, before 10 years back, when I used to read, then I was knowing that it is a not clear evidence. But nowadays, it is available, I think. The patients are getting it, but of course, not in our practice, it is routinely we are using this. But patients have options at the higher
So
center.
there is a two recent meta-analysis of IVIG used in recurrent miscarriage, and they found no evidence of improved live birth rates. This is a recent 2018 meta-analysis. However, a lot of work of IVIG has been done by Professor Christiansen, and he had a nice article in 2019 where he has said that IVIG has a documented clinical effect in many autoimmune diseases and has so far been tested in more than 10 randomized controlled trials in women with recurrent pregnancy loss. The results of the RCTs have, however, been very divergent. In meta-analysis of all trials, there was no significant impact on live birth rates, and it has been reported as such. In contrast, in sensitivity analysis, IVIG significantly increased live birth rates when initiated prior to conception, and it had a borderline significant therapeutic effect in women with secondary RPL. I told you, the secondary RPL is one where they had a child and then they went into recurrent pregnancy loss. But I would also, so there is a poor man's IVIG which is available in our literature. So intralipid.
We are giving that 21-day immunoglobulin injection, that Bharglobe kind of a thing, not IV immunoglobulin, but
that is another thing.
We are giving to number of patients actually now.
So, okay. So do you want to, Dr. Priyanka, tell us how you give it, the Bharglobe injection, or?
Sir, it's a 21-day injection actually. Intramuscularly it is given, but it is basically mix of lot of immunoglobulins actually.
Okay. Okay. So intralipids, has anyone used intralipids in their practice? So these intralipids are also, they may reduce peripheral blood natural killer cell, and this is a 20% fat emulsion of soybean oil, egg yolk, and phospholipid and glycerin. It is easily available in India for 300 rupees. So it's functions like IVIG only. The whole principle is based on that. There have been a lot of studies, and many people use it as a alternative to IVIG. Once in 3 weeks, you can give it. And there's a recent study by Darkley in 2016, where intralipid has been evaluated in only one RCT, wherein 250 ml infusion on the day of oocyte retrieval was given, and increased rates of ongoing pregnancy and live births were observed, the significance of which requires further investigation. So it is there and can be given, especially in repeated IVF failures. Our group uses intralipid. What about paternal leukocyte immunotherapy? Has anyone tried that, where they immunize the paternal this thing? So there is certain doctors who are doing it in the world, but there's not much. Again, there's a lot of controversy on it, and these studies need to be taken, and you have to be more careful of using it. There are other things like anti-tumor necrosis factor, that is adalimumab. So tocilizumab and all is being used in coronavirus treatment. Similar brother of that is TNF alpha, adalimumab, which is being also used. Only thing you have to be careful, because in that you have to see that if there's a latent tuberculosis, you can aggravate that latent tuberculosis. And as I told you, there are studies where granulocyte colony stimulating factor can also be used subcutaneously. And there are studies like this is a new study that has come, that a pilot RCT have found no benefit as such, but there are certain studies which founded benefit. And then there is this SPIN study, Scottish Pregnancy Intervention Study. So what about, how many of you use heparin, low dose heparin and aspirin empirically? You don't have any diagnosis, but miscarriage is there, and we would also add a heparin and aspirin. So how many of you have tried heparin and aspirin empirically in your practice? Bharti, have you tried it?
I have tried it so many times, and every time I got very good results with it.
Okay, so you feel that. So I personally feel that a lot of it, I also like the combination, but I feel it is more that many of these APLAs are being missed by the lab. So when we
that could be.
They are actually, we are, without our knowledge, we are treating the APLA syndromes. This is what I feel. So,
Sir, I never got a positive results with APLA.
Okay.
Got it so many times, but I started this empirically and got very good results.
So if you look at it, this was this spin trial where they found that there was no difference in the outcome in patients with unexplained RPL. But as I told you that in practice, a lot of people, even my group, we use it a lot. Even in our repeated IVF failures, we use it because recurrent implantation failure and repeated IVF failure and recurrent miscarriage, they're all similarly related cousins of each other. I think now we are coming to the end. So the last is the PGTA. As I told you, we can do it for unexplained high level multiple losses. We can offer pre-implantation genetic testing. And as I told you, the psychological support that, someone said in the beginning, TLC, but the TLC is the most important thing in recurrent pregnancy loss. And there are a lot of clinics in abroad where they do this TLC as a standard treatment protocol. And this was a study which was based on Pedersen's study, and it was a very old study where he showed that a cohort of 158 couples with 3 consecutive pregnancy losses and no otherwise identifiable etiologies were divided into 2 groups. One received routine obstetrical care during the next pregnancy, and the other additionally received TLC. TLC was defined as a psychological support with weekly medical and ultrasonographic examination and instructions to avoid heavy work, travel, sexual activity, and basically converse with the patient, give her a very we can understand, they want to express themselves. There were a lot of unhappiness, multiple miscarriages, and the difference, they found that the difference in livers was significant, 36% in the control group and 85% in the TLC group. So TLC psychology is very important in the support, and this is a recurrent pregnancy loss patients are prone to heightened anger, depression, anxiety, feeling of grief, and guilt also. There's a big guilt also that they have lost their child and all that. And there are 2 non-randomized studies which have shown significant improvement of subsequent pregnancy outcome with close monitoring and support at a dedicated recurrent. So recurrent pregnancy loss clinic dedicated, nice, when the patient enters, beautiful music, sonographic findings, then counselor, diet, lifestyle, exercise, all these things will contribute to this is called lifestyle modification, telling them not to reduce their weight, we cut down on their coffee intake, alcohol intake, reduce their smoking, cocaine, blah, blah. Of course, cocaine, we don't do it much in India. That's what I think. We don't know at the ground level. Eliminating smoking and alcohol and optimizing body mass index would benefit not only miscarriage, but also the risk profile. So, and of course, at the end, I've always found this surrogacy with exonation is a very big thing. And many people become pregnant with that. So, now I think we are now ending this. So I would like to all of you give us a one concluding remark. Let us start with Dr. Usha Sharma, our doyen.
Rishikesh, actually, after listening to your such a wonderful talk, in the end, I can say one thing, that if you ask me, I will never go to a treatment which is under research or which is in the publications, but I will like to follow evidence-based treatment so that at least we are also satisfied, the patient is also satisfied, and medico-legally also we are protected. So in my opinion, the evidence-based treatment like progesterone supplement and all these things, we can go for them, but these under research, all these things which we discussed today, I feel really a little bit apprehensive of using them.
Right. So as you said rightly, the ASRM has a very definitive indication. There are 4 main headings. If you can find them, like that anatomical is there. Then we have got endocrinology, which is definite indication. We have a Apla syndrome, which is a definite indication. And then we have the genetic indication. So if you have these, you treat it. If you can't treat it, then of course you can, we are all using the progesterone as a rule. That maybe we can add HCG to it. That's also okay. That's quite safe. We have no problem on that. And with that, hopefully we will be able to tide over the crisis by giving them tender loving care. Beyond that, the gray zone area of autoimmune disorder, as I
Yes.
told you, is a gray zone area which has got multiple treatments which are there. Someone does paternal glucoside antigen, someone will give IVIG, someone will give intralipid, someone may give heparin aspirin combination. All these are gray zone areas which you have to balance it out. And as Dr. Usha Sharma rightly said, that you have to be careful, because when there is a complication, then you have to be ready to face it also.
Yes.
So, now I would like to start with our president, who is sitting in the United States, Dr. Kirti. What is your final comments on our RPL? What is your take on it?
Dr. Pai, you have discussed everything from basics to up to date.
Yes.
And made us so clear in all investigations and evaluation. And what I feel that we should evaluate our patient. And once we have evaluated our patient and we can find out what is the cause, the treatable causes, as you have told us, that which is basically we are sure of and we are not doubtful, we should start the treatment, and together with tender love and care, we would end up into giving a live birth to her. That is what I think.
Yes.
So then I think I will go next to the 4 panelists, and then we'll give it to the chair to conclude the session. So Doctor, let's start with Dr. Priyanka Garg. What is your take? Dr. Priyanka?
Unmute yourself. Unmute yourself.
As an endoscopist, no ma'am, there's some problem with,
I think we'll come to her again.
Audible.
Am I audible now?
Yes, now you're audible.
Yeah. Ma'am, as an endoscopic surgeon, I would just like to add the role of hysteroscopy in RPL. Earlier, we used to put dilators of various sizes to just find out submucous fibroids, polyps.
That's true. Anatomical.
I think the signal is there. So,
Dr. Rishikesh, I have a question. Does endometrial scratching help in RPL?
No, it definitely helps in increasing pregnancy rate. That's again a controversial in IVF, but in RPL, I would not know. I don't think really.
Yes.
We don't know. I'll have to go back and read up whether there is any study on endometrial scratching and RPL. I will have to read up.
Studies are there, but it has not been found helpful in recurrent pregnancy loss.
Okay.
Sir, it has been said that it increases stem cells, which helps in endometrial restoration. Might be.
So I think Priyanka has come back. I think she was talking about hysteroscopy. Priyanka, unmute yourself.
Yes.
Priyanka, unmute.
Yes, sir. That was it actually. For hysteroscopy, office hysteroscopy actually can diagnose a lot of missed polyps, small submucous fibroids, even septum. And now, in conjunction with 3D ultrasound, like Sir has told, it is one of the very good modifiable causes of RPL, which is treatable and with good live birth rates.
Great. So I think that's all. So I think now we will ask Dr. Rastogi.
Yes.
And Dr. Nisha Jain. We have got 2, and
Dr.
then we'll end with Dr. Bharti Maheshwari's take on the pre-implantation genetic testing and IVF.
Thank you. Dr. Rishikesh, we are very thankful to having such an interactive session with you, starting from A to Z. I just wanted to make one comment that the chances of a miscarriage after 2 spontaneous abortion is about 30%, and after 3 spontaneous abortions, the chances are 33%. So they are almost same. So we must start investigating our patients after 2 spontaneous abortions, and we must focus on genetic the testing of the products of conception. We must switch over to microarray rather than doing karyotyping, because karyotyping cannot detect minor defects like translocations, inversions, deletions. It can only detect triploides or monosomies. So I am very much particular about doing microarray and products of conception. And that dictates us whether we should go for parental karyotyping or advanced genome exome sequencing. That can be dictated from the report of POCs.
Right. Actually, I totally agree. This is a very important point, and we must collect it in saline, and you can keep it in the refrigerator and send it, because ultimately it is DNA, so it can be amplified very well. So,
Yeah,
and it is now easily available everywhere. It is easily available everywhere, and it's not. It's reasonable. I think in 4-5 years time it will become 5,000 rupees or 2,000 rupees.
Yeah, sir, almost the same.
A lot of DNA labs have started. Even I have my own lab where we do the testing, and also we have a lot of DNA labs that have started in doing this. So this is a very important point which Madam has made, Dr. Rastogi. Now I would like to ask Dr. Jain her take on it and her comments on it.
Sir, I want to say simply, in low resource setting, sonosalpingography is helping a lot patients just to assess internal environment of uterus. So this is one of the good things which has to be in low risk, especially in India where we don't have hysteroscopy everywhere. So this is one of the things which can be promoted.
In fact, I was very, this is very important because we need to slowly, of course, it's a superb HSG, no one can replace, but we will have to slowly even use this as a tool for looking at our tubal testing as well. So, you know, rather than going for a HSG and an, radiation exposure, one can do a ultrasound, do this testing also, test the tubes as well in infertility workup. Almost all units in England are doing HICO-C as a regular basis, and we need to, this one test I have realized we have somehow not been able to do it on a large scale in India, so we need to really focus on that as well. So, so now Dr. Bharti, here's the final take on the subject, and then we'll go give it to the two umpires, Dr. Rukma and Dr. Manjula, who will do the final concluding remarks. But
winding up
before the final, the last batsman is yours. And what is your take on the PGT and all? What is your
Dr. Rishikesh Pai, you have covered each and every point, but there are one or two
कुछ कहना चाह रही थी.
अच्छा डॉक्टर रुकमा प्लीज आप अरे मैंने एक बड़ा पॉइंट पूरा भूल ही गया, सॉरी माफ करना मेरे को. आप जरा उस
infections Dr. Rishikesh, we
एंडोमेट्रियोसिस के बारे में बात किया मैंने, बट ट्यूबरकुलोसिस which is a big
tuberculosis मिस हो गई.
the genital tuberculosis में recurrent pregnancy loss होता है क्या मैडम? Because you people have got the maximum experience in UP, so my question to all of you.
Yes, sir, इसी बात पे आ रही थी कि you have missed one important point, that is genital tuberculosis.
Right. I was.
Number two, you were saying we must collect the products in the saline. I agree with that. But most of the time, these patients, they took MTP pills and all that, and it's very difficult to get the products for the examination. And once there is a chromosomal anomalies, it's very difficult to treat them. Only thing they require is psychotherapy, love,
tender loving care,
and affection, that they will be okay. And suppose there are 2 or 3 abortions, I know 2 or 3 cases in which we have to give at least a year gap. And in that time, we can treat them with the prednisolone, that is, and ecosprin, 150 milligram for another 11 months or 10 months. Definitely they respond that they are getting some treatment or folic acid. And these patients definitely require. The fourth thing, I agree that when we try this low molecular heparin and the ecosprin in first trimester, definitely we are getting very good results. And these patients, they respond. That is my point of view.
Madam, does tuberculosis, I wanted one question, does tuberculosis manifest as a RPL? What is, because you are the people who have the maximum experience on tuberculosis.
Mostly there is infertility, but not
they do
not RPL. So
not
tuberculosis
RPL.
Not an important player in the RPL area.
Yes.
So much so.
Sir, though it's
chronic endometritis,
but
chronic endometritis, adhesion,
they are the important cause of the recurrent abortion. So that we have to take.
Right. So tuberculosis is there everywhere now. of course, we have to add COVID to that whole thing because
Yes.
one more thing is a
we cannot ignore.
I always say that in India there is a zoo, and one more animal is now going to get added to that zoo in the form of COVID.
Yes, yes.
So I think Dr.
Very
Bharti,
nice.
some few words from you, and then we'll conclude after. And Dr. Manjula, I
There's
think
some questions and answers from the audience as well.
Okay. So I think Dr. Bharti, after Bharti will pick. Yes, Dr. Bharti, what is your take on it?
But it was wonderful interaction. Very nice discussion.
So thank you,
Really,
Dr.
Rishikesh, maza aa gaya aaj bilkul.
Thank you.
Thank you.
Very nice.
Yeah, thank you, Dr. Rishikesh sir, and all esteemed doctors' input. And in the last, I would like to say that whenever any patient for RPL, recurrent pregnancy loss, comes to us, we are in whatever settings are two aims that are the cost-effective optimal treatment. And as Dr. Pai has told us lots of causes, of course, genetic is one important cause. Besides that, there are many causes. So first and foremost thing is, of course, from very beginning, the psychological touch with the patients or proper counseling and sympathy with that proper history taking. That is very important. And like type and trends of the like pregnancy failures, as well as many things, what types, how the pregnancy has failed, that gives lots of clues regarding the etiology. So that is very important. And past history, like some related to the immunological, like she has a history of preterm, she has a abruptio, she has a history of preeclampsia, like immunological hints for the immunological causes. And then accordingly, in all patients, I go for the certain basic investigation. And for that, we can find out around 70% of causes that are confirmed, that are certain basic investigations, hormonal evaluations for TSH, prolactin, and diabetes. And beside that, thyroid antibodies. It is many times said that though TSH is not raised and though there is a subclinical hypothyroidism, but if thyroid antibodies are there, even in the cases of IVF, the preliminary test, we go for the thyroid antibodies because it causes sometimes the recurrent implantation failures, or in the pregnancies, recurrent abortions. These are coming gradually in our cases. And the third thing, of course, the uterine anomalies, hysteroscopy is a very important role, or the ultrasonography, where we can find out many things, even by the ultrasound. A doctor said that there's subtate uterus and biconvex uterus. And even if we are not having the 3D ultrasound, so we can have, and even after proper septal dissection, we say that immediately the patient gets a good pregnancy. So that is the important. And then, as sir has said, that the option that there is a recurrent pregnancy failure, the genetic counseling, if we didn't get any abnormalities, any factors, then of course, most of the time, 50% cases, we didn't get anything. It could be unexplained. And as awareness for the product of conceptions, for the microarrays and for the genetic abnormalities, it is increasing, and we should aware the patient that we should try to find out these things. And NIPT, of course, it is a costly, but it has role. And besides that, we all must know that role of prenatal genetic diagnosis, because it is not unreachable now, and it is not many times we can get it. So if we can get it, and patients, then as madam has said, then the patient have 4 or 5 options, because all congenital anomalies, they are not like that they will recur in every pregnancy. So patient can have option, either she can continue with the same things, or she can go for the prenatal genetic diagnosis, and or next things, whatever she can have, opt for the ART. So that is the things what I want to give message, that we should update ourselves, as well as we should know where these tests are available, and we can offer those to the patients. And of course, tender loving care is the main history of the
I think one person, that's very good. And one person who has not given a final word is Dr. Manjula. And so Dr. Manjula, would you like to say anything before we go to the question answer quickly, and then go for a nice...
Yes, Dr. Rishikesh, this has been an excellent talk and very well highlighted. I think what I would like to say is that we go to our basics, start with history, then we go to investigations, as you have told, microarray and 3D ultrasound, hysteroscopy, all are very important. Then we have to have the treatment must be tailor-made. We must see the age of the patient, how much we have to investigate. And now these days, as the elderly, because of late marriages, The patients are already late in receiving, so we cannot wait for multiple pregnancy losses. But there are some groups where we have girls who get married at the age of 20, 21 also. So we have to consider all these points. Therefore, all our treatment and investigation should be tailor-made. And accordingly, we must treat the patients.
Okay, great.
So
great.
we have had a very wonderful discussion. I will not go into a detail of highlighting, but compassion is very important. Giving psychological therapy to our patients is very important. As you said, surrogate mother, she conceives, and a normal mother might not continue that pregnancy because the surrogate is tension-free. So we have to allay the tension of our
That is the one point I didn't notice.
Yes.
This is a big point I gained today.
Yes, we have to. That is the most important thing. And today, these days, we are going into Garg Sanskar, where we tell them to listen to nice music, have nice food, have good surroundings. So I think that also should be a part of a holistic approach to this problem.
I think that's a very good
very
point.
Well
That's
covered.
a very good point.
Congratulations to you. So I think we should all have a holistic approach and have a tailor-made treatment. And thank you, Dr. Pai, for a lovely session today.
Okay, so I think the question we take, or we now stop it. What is it you would like to ask?
Just 5 minutes. So just 5 minutes. Please. There are lot many questions from the audience. Just quick take. So first is, what is the role of dexamethasone? I think you have covered in fetal bradycardia. You want to use methylprednisolone.
Yeah. You can use Decadron also. You can use Decadron also.
Yes.
Dexamethasone.
When should we ideally start progesterone?
I mean, after, you can, in a IUI or IVF, you would start it after transfer, but in a recurrent pregnancy loss, once the patient is pregnant, beta HCG is positive, we would start it. Is there any, please, audience can also answer this question. You are a part of the panel. All of you are highly experienced, so I would like to listen to you so that I can gain from all of you rather than me talking.
I would like to add here, Dr. Pai, sometimes it happens that even before your test becomes positive, after a few days, you realize that the patient has past products. So even giving luteal phase support continued with pregnancy, and we can do beta HCG in early, so that even if the urine test is not positive, beta HCG we can approve with that and then continue the progesterone.
Okay.
Because
anyone else would like to add to it?
Then role of MRI in detecting uterine anomalies. The next question, sir. Any take on it?
So just now I was reading in the fertility study before I joined this program. So they are saying that MRI, if there are multiple fibroids, especially if you want to look at the distance of, because there's a lot of people who are saying that the distance of the fibroid from the endometrium, if it is less than 1 centimeter, that can also cause expression of the endometrial Hox genes, and all expression can be altered. So MRI, but it's a very costly, and somehow I am not happy using MRI in gynecology. I feel that we should, with the information that I would gain from a nice 3D ultrasound is better.
Yes.
Of course, MRI can be used for, there are a lot of moments like adenomyosis, or you want to find out whether there is a some malignant change occurring in a if you are suspecting in a fibroid, endometriomas, all that. There is a place for MRI, but it's not really that.
3D ultrasound is more than enough for us.
Yeah, I think 3D, good
not
3D.
Not a question from this topic, but kahin par bhi hota hai to ye hota hai. There's a question on COVID vaccine in pregnancy. Do you advocate that or not?
So my answer is, because I was waiting, I phoned Dr. Alpesh also and Dr. Dam, because this is the question, because I feel that the vaccine should be taken. So there are three groups of
should be given. Should be given.
Yeah,
should
three
be
groups
given.
of people. And so Foxy statement, that's what I phoned them and said, you please come out with the Foxy statement. And because in the United States, the 90,000 healthcare workers have taken the Pfizer vaccine, and it is quite safe. And I don't see why the Covishield should not be safe also, like the Pfizer vaccine.
Foxy
So I
is
don't see
sending.
that any reason
No.
we should not take the vaccine in pregnancy.
Even in breastfeeding, they say vaccination should be given.
And Priyanka, Foxy is sending recommendations to government for the vaccinations, I think.
Yes.
Yeah, in pregnancy.
But you know, the latest recommendation that Foxy has not, they have not mentioned about pregnancy and lactation, but I think they are coming out with a GCPR.
They are coming out, yes.
So I hope it comes out quickly, because people are phoning and to say, because government has said that you can't take it in pregnancy.
Yes.
The government stand is you can't take it on pregnancy. So if we say something contradictory, we need to have a backing of the federation at least.
You know, actually, Rishikesh, we have to weigh between advantages and disadvantages. So if personally you just think of it, in my opinion, even in breastfeeding mothers, why vaccination should be
Yeah, I totally agree with that. They should give.
Yes.
I totally agree.
Yes.
So what about
you know what I'm scared, you know, they should not do say some act and say Dr. Pai, you're saying wrong things.
No. That's
no, in the sense that I'm waiting for the guidance from the Foxy. When the Foxy guidance comes, which is a collective guidance.
You are right.
You know, then we can say bindas na. Abhi hum log dar ke baat nahi kar rahe hain.
और तुम्हारा बोलना तो एक अथॉरिटी का बोलना हो जाएगा ना, इसलिए
इस चीज को पोर्टल एक्सेप्ट करता है. डज पोर्टल आस्क कि आप प्रेग्नेंट हैं या नहीं? आई डोंट नो. मतलब एक्चुअली यू नीड टू रजिस्टर ऑन द पोर्टल फॉर द वैक्सीनेशन.
Yeah, so there is an issue there.
पोर्टल तो शायद नहीं पूछता, पता नहीं है बहुत.
पता नहीं मैम, अगर पूछेगा तो हम नहीं कर सकते. हाँ जी.
हाँ, नहीं मेरे ख्याल से पोर्टल में तो नहीं पूछते हैं.
नहीं, पोर्टल में नहीं है. गवर्नमेंट has said you can't give vaccine in pregnancy. So now we are in that controversial area, but I think within a month's time it will be sorted out.
Okay.
So
very nice.
IgG last question, sir. Herpes IgG positive. So ma'am, audiences के question है. And herpes IgM positive. Can this cause RPL at 10 weeks of pregnancy?
No, I think that, all these infections are not, they can call sporadic abortion, but not recurrent abortion. So it's quite clear on that most of these infections, unless there is a chronic endometritis, which is a totally different entity.
This is not actually the cause of RPL as such.
Anyway,
present pregnancy is affected by this.
Yeah. So I think that more or less we have covered everything. And
more or less नहीं, काफी ज़्यादा cover कर लिया.
तो ऐसा लग रहा है ये चाय पे चर्चा चलती रहनी चाहिए.
Thank you.
Tail is behind me, madam. Time खत्म हो रहा है. Time खत्म.
Priyanka, it was so nice to be here in this program, and
thank you very much.
I have no words to appreciate your talk as well as your discussions. It was really, really very nice, and we have learned so many things today.
Thank you.
बहुत अच्छा रहा.
Thank you so much. Thank you.
Thank you all. Please stay.
ऋषिकेश को पकड़ने के लिए.
Pray to God, all of us, that all of
yes.
Stay safe. Bye.
Sure.
Thank you.
Okay.
Bye.
Thank you, ma'am.
Thank you, sir.
Thank you.
And all our audiences, we had more than 500 today.
Oh, very good.
Thank you. I think we should thank Payal Ota also. Payal has done a good job.
Yes. Payal, thank you very much, Payal.
From the entire team of Human Biological Institute, ma'am, I thank all of you.
Thank you very much, Beta. You have done a great job.
Thank you, ma'am. It was a pleasure seeing all of you together in this platform, and specifically during these challenging times when the entire mindset is so negative. But I'm sure this program, the discussion that you all had with each other, जो भी हमारे audience होंगे आज, it would have benefited them a lot. Sincerely, thank you so much.
चलो एक फोटो लेता हूँ.
Thank you.
This is TLC. हम सबका आपस में TLC, tender and loving
TLC, which is working exactly.
डॉक्टर ऋषिकेश एक फोटो तो ले लो.
हाँ, फोटो लिया ना, वापस लेता हूँ.
Dr. Anju Rastogi, ma'am, may I please request you to turn on.
Dr. Anju Rastogi, please open your video.
Dr. Pai sir, congratulations for your president-elect because we are
Thank
meeting you.
yes.
Congratulations, sir.
Election.
भैया ये भी नहीं कह सकते मिठाई खिलाओ पार्टी खिलाओ
सब होगा सर के टाइम तक सब ठीक हो जाएगा.
एकदम जोरदार पार्टी देंगे और अपने को सबको
रखेंगे मैम
अपने को सबको ना बड़ा एक we have to rebuild our country also. Our country needs a lot of rebuilding in the next 5 years.
we should
And
request
one
Dr. Pai
thing
to
before I leave, I would
visit
like to say that what we have realized that population is too much. We have to control the population. This is going to be my slogan only. My Foxy here. We have to control the population. The resources
That's
have gone totally out of
Very true.
Yeah, ये सब population की problem तो हो रही है,
Yes,
otherwise control हो जाता.
इतना पूरा सब
पर
मैडम
क्या
इतना
करो?
70 बरस का प्रोग्रेस पानी में गया है.
ये political interference, my God, you cannot implement any law knowingly
Chalo,
that.
I think that we'll have
Chalo,
to take
it's
the
all right.
photo. We'll take a
Yes,
photo.
ma'am has come. Ma'am has come.
Bye.
Sir, I'll take it, sir. I'll take it.
Okay.
कौन ले रहा है?
I मैं
Ma'am, मैं ले रही
चश्मा
हूँ.
निकालता हूँ.
Thank you so much, sir. I'll share it with
You know,
all.
if I don't wear the chashma, I can't see all the beautiful women in front of me.
सर आपने बहुत देर से देख लिया सबको.
तो रुक्मा ने ठीक कहा, तुम तो आज कृष्ण कन्हैया हो.
क्या ये अभी मैडम डिजिटली हूँ.
Very sad, very sad.
मैंने कहा कृष्णा.
Okay, bye.
Thank you.
Bye.
Bye.
Bye.